Okay, hello everyone. Welcome to the Achieving Racial Equity in Healthcare panel. We are delighted to have you here today. Just so you know, this panel is recorded. My name is Sanjeet Rajaram, and I will serve as your moderator this afternoon. It is my honor and privilege to introduce three amazing speakers to you today. Okay, our first speaker is Dr. Anjanette Wells. Dr. Wells is an associate professor in the School of Social Work at the University of Cincinnati. She joined UC 4 years ago as a researcher with the Precision Cancer Cluster, and she has substantial direct practice experience in outpatient community clinics, inpatient hospitals, psychiatric units, and private practice. Her research focuses on community-based cancer prevention and adherence among low-income and minority women. Recently, Dr. Wells lead authored a book published last year entitled Poverty in Place: Cancer Prevention Among Low-Income Women of Color. Her teaching focuses on advanced clinical social work practice, research methods, diversity, and theory courses. We are delighted to have you here, Dr. Wells. Our second speaker today is Juliana Matzai. Juliana is a fourth-year MD PhD student in sociology at the University of Cincinnati College of Medicine. Her dissertation work is focused on increasing access to gender-affirming care for transgender and non-binary people and improving the quality of care that queer and trans patients receive within the healthcare system. Juliana also works as a research assistant for the Ohio Policy Evaluation Network, conducting rigorous, impactful, and forward-thinking social science research on the reproductive health of Ohioans in the context of federal and state laws, regulations, and policies. Outside of academia, Juliana serves as an editorial board member and writer for Pride in Practice, an online publication dedicated to empowering healthcare providers with the information they need to give excellent care to people of all sexual orientations, gender identities, and differences in sex development. We are so excited to hear from your perspective, Juliana. Our last speaker for today is Dr. Amuta Onakaga. Dr. Amuta Onakaga is an associate professor in the Department of Public Health and Community Medicine at the Tufts University School of Medicine. She has a long-standing commitment to public health that spans over 15 years of experience. Her current research interests include maternal mortality and morbidity, health disparities, reproductive health, infant mortality, and HIV and AIDS in women of color. Dr. Amuta Onakaga is a member of the American Public Health Association and is currently the co-chair of the Perinatal and Women's Health Committee in the Maternal and Child Health section. She is a former president of the Society of African American Public Health Issues and currently serves on the board of directors for the National Women's Health Network. In July 2020, Dr. Amuta Onakaga helped to pass the bill H4818, which focuses on reducing racial inequities in maternal health. She is also an active member of the steering committee for the Massachusetts COVID-19 Maternal Equity Coalition. She also has recently written a book titled The Black Women's Guide to Advancing in Academia, an excellent resource for career development for women of color. We are so excited to learn from you, Dr. Amuta Onakaga. Today's panel discussion will first start off with presentations from each of our three speakers, and then we'll move on to questions from myself, and then the next half of the panel will include mainly questions from the audience. So please, if you have any questions, use the Q&A function on Zoom webinar and we will try our best to get to it. Thank you so much everyone for tuning in today, and let's begin. Our first presentation is from Dr. Wells. Dr. Wells, we aren't able to hear you at the moment. Awesome. I can hear you now.
Okay, all right, let me share my screen again. Let's see. Okay, is that okay?
You are in presenter view at the moment.
Okay.
Yep, if you can just switch those displays for us, please.
Like that?
That looks great. Thank you so much.
Okay, thanks. So these quotes really resonate with my work and with how I see disparities and inequities as more than just a medical and scientific issue, but also a social justice and moral commitment to really understanding and addressing some of the many racial, ethnic, age-related, economic, sexual orientation, gender inequalities, inequities, and injustice throughout the life course. And I'll talk about it in a minute. When we speak about health inequities, we're also speaking about societal issues like access, poverty, homelessness, mental health, racism, bias. So these quotes really kind of get at the core of my work in cancer disparities. Okay, so just there have been several experiences and people who've been really influential in my work, and most notable was here a very close friend of mine who I started my Master's of Social Work with. She was in her 40s, she was divorced, a single mom of a teenage daughter, Ethiopian immigrant without much support. She lived in a low-income housing complex in central Los Angeles. She was diagnosed with breast cancer during our master's program, and she passed away a semester before we graduated. And I began to become interested in barriers and challenges that low-income women who are working, going to school, trying to make ends meet, the experiences that they were having, but also while dealing with illness and disease. Another influential person in my work was one of my first practicum supervisors at the VA outpatient clinic downtown Los Angeles. And she really exposed me to community settings. So not only starting with where the patient is, but sometimes needing to go directly into the communities, into neighborhoods. To provide needed education resources. So my interest in cancer adherence and screening began as a doctoral student. I was a interventionist on a large cancer clinical trial. And the trial accounted for a lot of the known barriers that we see. We provided transportation, we provided bilingual education. We adapted material for low literacy patients. We culturally matched the providers, reminder phone calls, provided flexibility in scheduling, childcare. However, there were still patients who were not adherent and who did not complete the intervention. So that was that was who I was really interested in. And this is kind of the beginnings of my work in looking at sociocultural issues. So before I just give a brief um, uh, lecture on or talk on some of my work, I want to just define a couple of things. Racism is discrimination directed against a person or people of a particular racial ethnic group, typically one that is a minority or marginalized group. So most of the conversations that we hear a lot of times are on this individual internalized racism, interpersonal racism. However, And I'll speak about these levels just very briefly, and we'll probably cover it a little bit more in the Q&A. But systemic racism, which is more at the institutional and structural level, is even more pervasive oftentimes. It's a pervasive driver of poor outcomes faced by communities of color. So I won't go into each of these definitions for each of these levels, but this is a really, I think, important slide that talks about racism being a negative social determinant of health, and it can, which can actually affect disparities in overall health and outcomes. So this shows the connections between racism and health. As shown here, racism impacts both directly and indirectly through traumatic events, violence, toxic stress, stigma, and also these policy and systemic inequities. And this is kind of what my work focuses quite a bit on, are some of these social determinants of health. And then this shows how it impacts health behaviors as well as overall outcomes. So this is kind of one of some of the results of an early study that I did, which showed these sociocultural issues of mistrust being a barrier to represent or to uptake of cancer clinical trials. So I conducted a study describing psychosocial barriers contributing to the underrepresentation of ethnic minorities in cancer clinical trials. And interestingly, we found that past historical injustices still permeate current perceptions of mistrust and create barriers for uptake. This is a study that also looked at negative determinants of health, and I think for this one, it's important to point out that it's not only, race, ethnicity, but it's kind of the intersection of race, income, education, which often leads to some of these outcomes. So here they found that trust leads to increased patient satisfaction and better compliance. However, for African Americans, those with less than a high school education and those at or below the poverty level, it's often difficult to find a trusted healthcare provider. It's not always easy. This is a program, actually it just came out in one of our newspapers here at the University of Cincinnati. And I think it's interesting because it's in direct response to research that's been found that middle-aged and older African-American males who are the most vulnerable at-risk group to multiple health disorders have better outcomes when treated by African-American male physicians, whether it be related to trust or compliance or a combination of those factors. A physician, I think he's a pediatric orthopedic doctor. He launched a program here at UC this year designed to mentor Black males in medical school. It's called the Black Men in Medicine Cincinnati, and it's still in its infancy, but it attempts to pair incoming medical students with older medical students and those who are closer to completing their medical degree with residents and attending physicians. So it's, the camaraderie, the networking, and also defined social support might ease the isolation and lead to a boost in numbers of Black male physicians. I'm not going to read all of these quotes here, but this is a recent study. It's under review at with Public Health and Practice, and some data we collected last year. We wanted to better understand factors that affect cervical cancer screening and testing adherence, but we looked at it from a provider perspective. So this was a qualitative study, and these are just some really insightful quotes from the providers in the clinic, but also some of the community health workers. And they talk a lot about this trust that's so important with regard to adherence. And this is a conceptual model for illustrating the link between community-based participatory research and policymaking. So these researchers here have said there's really insufficient attention that's been given to how research can leverage to promote health policy, and how locality-based research strategies, in particular community-based participatory research, can help with ultimately outcomes. So starts off, the idea is that within the context of past historical injustices and resulting mistrust, that we should partner with these communities in a collaborative way to inform policy change, and thus with policy change that will help improve outcomes. So ultimately bringing people together, and academics going into the community, building networks can help with these outcomes. This is just really kind of a snapshot of some of the work I've been doing probably over the past 10 years. Started in St. Louis, Missouri. I began kind of engaging in communities where the highest cancer mortality rates existed. And you can see in the pink circle there, we identified zip codes which clustered in this sort of north side of St. Louis City. We partnered with community businesses where health wasn't necessarily on folks' minds, in non-health sites like hair and nail salons, churches, laundromats, social service agencies, libraries. So this is kind of ongoing, and I think there's one thing that sort of I think is important here. We did some work interviewing hairstylists, and we're kind of transitioning some of those findings to Cincinnati, but they discussed the kind of the natural trusting relationship between the client and the stylist that really that transcends the business relationship, and they were interested in developing or being a part of interventions, and being sort of community ambassadors to education with their clients. And this is some of the work that similar to St. Louis, Cincinnati represents a large, highly segregated urban community burdened by many of these same disparities, cancer disparities. And so here, we're focusing on in these zip codes with high cancer mortality and high community needs index score. And the red star is where the University of Cincinnati is located. So I guess, the question that we really want to kind of take on and begin to think about are really actionable steps that we can take. This diagram just shows the different levels that are important to addressing this issue of eliminating racism. And one of the things that I think we still need to do a better job about is to acknowledge that racism is a crisis. So explicitly acknowledging that racism exists and the profound effect it has on communities of color. And then also to rebuild community trust, which is important, and which I think speaks to community-based participatory efforts. Also, I think this is probably the most difficult oftentimes. No one wants to give up power. And so often, people are in institutions are, you know, they're kind of comfortable with the status quo. So, but really there does need to be an extension and sharing of power with communities where these disparities exist. And then sustaining efforts over time. I won't go into it much more. So just a couple slides here. And I'm sure all of you know kind of the much anticipated launch of Healthy People 2030. So here, I think just like 2020, there was a focus on social determinants of health. But the thing that's different with the 2030 focus is that there's more of a, I guess, emphasis on metrics that really matter. So I want to just point out that it's not only big data, but it's also other non-traditional methods that can help inform policy and outcomes. And I'm just going to leave this with a couple of new insights that help illustrate the intersection, I think, between research, you know, us as academics, social and physical scientists, policy, and the community. And so I think these kind of really resonate with the direction of my work, and also I think where we need to go. So thank you, and I'll turn it over to Sunny for the next presenter.
That was an awesome short lecture, Dr. Wells. Our next speaker is going to be Juliana Matsai, who is going to present about structural racism in the clinic in medical discourse. So if you can share your screen.
Hi, everyone. Thank you for having me here to talk with you today. Let me get my slides pulled up here. So today I'm going to talk about a project looking at the impact of structural racism and place-based stressors on Black maternal mortality. This project will fill a unique space in the existing literature by situating residential segregation, community deprivation, and air pollution exposure in the historical context of racialized policies that have targeted and exploited Black communities, and will consider how the effects of such policies continue to harm Black pregnant people today. The maternal mortality rate in the US increased 25% from 2000 to 2014, and was one of only 8 countries in the world that saw an increase in maternal mortality during this time. According to the CDC, at least half of these deaths are preventable. There are significant racial disparities in maternal mortality, with Black women being 3 to 4 times more likely to die during or within 1 year after pregnancy than white women. There are various hypotheses for the increase in maternal mortality and their disproportionate effect among Black communities. But first, I want to give a few notes for this presentation. Because this is a study that evaluates the causes of racial disparities in maternal mortality, I want to emphasize that this in no way implies that there are racial differences based in genetics. Race is socially constructed. It's not a biological fact. And it's the conditions that place Black pregnant people at greater risk for maternal mortality and other negative health outcomes that are also socially constructed through racist ideologies, policies, and medical practices. It's racism and the social conditions it fosters that are to blame for any racial differences in the values of variables examined in this study, not inherent biological difference. And I'll take great care to reflect this language or to reflect this in anything that comes out of this project. And further, I recognize that not all people who are pregnant identify as women, and that for transgender and non-binary pregnant people, the word maternal may not be an accurate representation of their parental identity. And so I use the term maternal mortality to reflect language used in existing literature on the topic and in calculations of vital statistics on pregnancy-related death. But when using my own words, I choose to use pregnant people instead of pregnant women to more accurately reflect gender diversity among people who become pregnant. And then finally, I acknowledge that my identity as a white woman trained in the American medical education system influences the way that I think about and approach the study of Black pregnancy-related death from the methods and variables I choose to the way that I will draw conclusions from my data. So to the possible explanations for the disproportionate increase in pregnancy-related death among Black people, there are individual level factors wherein Black people are already more likely to have comorbidities like hypertension and cardiac disease due to systemic inequalities in access to resources. And these comorbidities make pregnancy-related death more likely. There are also systems level factors, such as Black people being more likely to enter the healthcare system at a later point in the course of a disease because of the unaffordability of preventive care, and delayed referral to higher levels of care because of healthcare providers' incorrect race-based assumptions about which patients are truly sick. And there are place-based factors of where one lives and works, like being exposed to harmful environmental toxins, living in segregated communities, which may have greater levels of economic stress, or may be more remote from high-quality hospitals. And each of these problems likely interact with each other to create the disparity in Black maternal mortality, but this project primarily focuses on the place-based factors. And much of the previous research on this topic has included little historical context or social theory to contextualize the problem within a history of racism in the built environment. So the way that I frame the problem in my research is that structural racism in housing policies and zoning laws has directly contributed to residential segregation and community deprivation. Residential segregation and community deprivation have already been linked to adverse birth outcomes such as preterm birth, but not conclusively to pregnancy-related death. This may occur via the direct impact of experiencing racism across the lifespan. The long-term stress that the experience of racism puts on the body may also increase susceptibility to the harmful effects of air pollution. My goal with this project is to determine how exposure to place-based stressors, including particulate matter or PM2.5, community deprivation, and residential segregation, impact the risk for maternal mortality, and how these stressors interact with one another. PM2.5 is the most common type of inhaled air pollutant used in studies of effects of air pollution on human health. Residential segregation is the degree to which two or more groups live apart from one another. And community deprivation is a quantification of neighborhood poverty, disadvantage, and disinvestment using 6 different census tract level variables related to material deprivation, such as household income, insurance coverage data, usage of public assistance, and fraction of houses that are vacant. And here you can see where the variables I include in my study fit into the broader context of the social and environmental issues related to Black pregnancy-related death risk, with the red arrows representing the relationships that I will examine. The two main theories on which I'm building with this project are Geronimus's weathering hypothesis and Krieger's eco-social theory. The weathering hypothesis states that Black people in the US experience early health deterioration due to the cumulative impact of repeated experience of social or economic adversity and political marginalization. Coping with acute and chronic stressors can have a profound effect on both physical and mental health. The stress of living in a race-conscious society that stigmatizes and disadvantages Black people may cause disproportionate physiological deterioration. This deterioration in health accumulates, producing ever greater racial inequality in health with age. Eco-social theory states that people embody, biologically, their lived societal and ecological experiences. This creates population-level patterns of health and disease. Pathways of embodiment include exposure to social and economic deprivation, exogenous hazards, social trauma, targeted marketing of harmful commodities, and inadequate or degrading healthcare. Epidemiological profiles are then shaped by societal arrangements of power, property, and the production and reproduction of social and biological life. In societies with social divisions based on power and property, such as ours, those with less power and fewer resources will bear a greater absolute disease burden. And my data will be drawn from the Maternal Infant Data Hub, which is a regional geocoded data repository that integrates maternal, neonatal, and pediatric patient records across the greater Cincinnati region. This data set includes 95% of live births that occur in Hamilton County, Ohio. I will then link this data set with Ohio death records and electronic health records from the University of Cincinnati Medical Center to identify cases of pregnancy-related death and the causes associated with each death. Since every individual in the data hub is geocoded to a residential address, I can then use a PM2.5 exposure prediction model, as well as the community deprivation index and an index of dissimilarity for residential segregation to assign a numerical value of air pollution exposure, community deprivation, and residential segregation to each case. I have three main hypotheses. First, I hypothesize that increased community deprivation and residential segregation are associated with greater risk of maternal mortality. Second, I hypothesize that increased air pollution exposure is also associated with greater risk of maternal mortality. And finally, I hypothesize that air pollution exposure mediates the impact of social stressors, specifically community deprivation and residential segregation, on maternal mortality risk. And if particular hotspots of pregnancy-related death, air pollution, residential segregation, and community deprivation are identified, I will dive deeper into the policy context of those neighborhoods to determine why the hotspots exist where they do, and what policies remain in place today that perpetuate disparities in environmental exposures and health outcomes. Efforts to change housing and environmental policy should first focus on these communities, with the ultimate goal of creating change in our cities such that the neighborhood you live in doesn't determine how likely you are to die during pregnancy. And that's it. Thank you.
Awesome. Thank you so much for the overview of your project. Our last speaker for today is going to be Dr. Amuta Nakaga. So if you can present your screen.
Great. Good afternoon, everyone. Can you all hear me?
Yes.
Yes.
Great. Thank you. So thank you to the National Science Policy Symposium for having me today. Thank you to our moderators, and thank you to both of my co-presenters. I'm actually going to touch on a little bit of maternal health work that I'm doing as well. So I'm glad that I was able to kind of see my previous presenter so I can trim some of the background and just give you guys an overview with the time that we have left. So as you all have already heard, maternal mortality rates in the United States are increasing, and we are one of the few developed countries that rates are actually going in the wrong direction, and that's for myriad reasons, as we've already heard from our previous presenter. And just to give context that the rates are really exacerbated for Black women, and there are a number of reasons that that is occurring, including but not limited to racism, including maternal hypertension, maternal hemorrhage, and other pregnancy-related complications. So these disparities that we see are not only in maternal mortality and morbidity, but we also see them for Black women and other reproductive health outcomes, such as Black women are more likely to die from heart disease, Black women are more likely to have pregnancy or related complications, and then we see these disparities play out in different types of cancer as well. And that is for many reasons, including the ones I mentioned earlier, but also that there is a very limited diversity in the medical profession overall. So I just want to give an example of data from Boston, which is where I'm housed, and looking at the percentage of overall U.S. doctors who are Black, which is around 4%, and then breaking it down by some of the local hospitals here, we know that there is definitely a pipeline problem. There's definitely a paucity of researchers and medical facility personnel that are committed to addressing this work, and that come from communities of color. So overall, there's a very limited diversity of people of color in the medical profession. So I represent 3% of medical school faculty that are Black, and I represent less than 2% of NIH-funded principal investigators that are Black. So we see that this issue of trying to address maternal health disparities is really complex because we, one, need to have more funding going to clinicians and researchers that come from communities of color. Two, we need more clinicians and researchers in the medical profession to be able to increase the likelihood of culturally congruent care. And three, we need to really eliminate the structural racism that we see impact so many Black women in pregnancy. So I wanted to spend my remaining time kind of talking through some of the work that I'm doing and how I think the work can be relevant for this audience. So if any of you guys follow me on Twitter, which I put on the last slide, so you can pick up my Twitter handle, I'm starting a new research lab, really training the next generation of maternal health scholar activists. Majority of them are from the Boston area, but I do have students that from across the country. And it's from undergrad, master's, MD, PhD, postdoc, the whole spectrum. And it's called the Mother Lab, which stands for Maternal Outcomes for Translational Health Equity Research. So it's a mixed methods, multidisciplinary lab, all students, all backgrounds, and really focusing on addressing and eradicating inequities facing Black women through research, advocacy, mentorship, by confronting and dismantling the system that enables and perpetuates racism for Black women who give birth. So the lab has three main committees: a research and grants committee, and that committee is focused on exactly what it sounds like, developing pilot research projects, supporting my research that I'll talk about in a minute, and also disseminating scientific literature on the topic of maternal health disparities and severe maternal morbidity, and really anything in the reproductive health disparities world. So we already, the lab is just a few months old. We just started over the summer, but we already are going to be doing a webinar on Wednesday of this week, so you can register. I can actually drop the Eventbrite link in the chat during the Q&A. And we already have a paper under review. We have book chapters that are in development, and we are applying for funding. So that's really exciting. And then we have our community engagement, advocacy, and policy committee that's focused on keeping abreast of the local and state policy around maternal health disparities and federal policy, and also working with community partners here in the greater Boston or New England area to support the smaller nonprofit organizations and provide resources, provide student support for the work they're doing on the ground in the form of working with doulas, midwives, community partners, public health organizations, et cetera. And then we have a marketing, communications, and events committee that kind of does the branding and social media. And then I mentioned the writing committees and some of the deliverables that they're going to be working on. And then I'm also really big on providing opportunities for peer-based mentorship, and then developing a formal mentoring committee comprised of me and other maternal health advocates from around the country that can support the students. And I have about 35 students in the lab. So some of our goals are to address maternal and child health inequities for Black women through focused research and policy, addressing it at both the local level, so being a resource here in the greater Boston area, but also Massachusetts, acquiring funding, right, for research, for stipend, for lab-related needs, educating our local and national community through webinars. As I mentioned, we have our first one on Thursday, sharing information, just being a resource for other scholars, other active people that are working and reducing disparities in maternal health for Black women, creating strong partnerships to make our lab one of the largest in the country, and create and foster a welcoming and inclusive research and professional development, really. So training the students up, giving them tangible skills in research, data collection, presentation skills, grant writing, et cetera, so that when they go into the world and they go into medical school or doctoral programs or master's program or whatever is on their pipeline, they have the skills to be able to be really competent and attractive and a resource in these spaces for people who are passionate about maternal health inequities, with the focus on representing people of color. So I want to shift now and talk briefly about some of the research that I've been funded to do, and I'm happy to answer any questions during the Q&A. But I just recently received an R1 from NIH, and that has three aims, really. One, focusing on looking at hospital discharge data, and then using a data set germane to Massachusetts called the Pell data set, which has some really cool data points in there that have things about preconception, prenatal, postpartum. Also looking at the role of hospital discharge data and really trying to pull out the highest risk women for severe maternal morbidity, and also the women that are more likely to have near miss or to be at increased risk for experiencing maternal mortality. Working with hospitals that serve Black women to really look at the role of maternal safety bundles. And so we know that there are certain safety bundles that can really have an impact on a woman's chances of survival, right? Maternal hypertension, maternal hemorrhage, and racial disparities. So those are the three safety bundles that we're going to be implementing. And then examining how systems integrating community-based dual support can decrease the inequities around severe maternal morbidity that we see in Black women. Also, I was recently funded to focus on money from the Robert Wood Johnson Foundation around collaborative community-based work. And so I am one of three co-PIs focusing on looking at maternity care choices, patient empowerment, from a mixed methods approach. So we're going to be working with pregnant and parenting women, partners, doulas, practitioners, et cetera, to really get at what is the level of awareness here in the greater Boston area, and how can we create a teaming environment with a focus on birth equity? So how do we get all the players around the table from a community engaged approach, right? You're working with providers and the partners and the women themselves, and it's really looking at it from a multifaceted but mixed methods approach. And then finally, I just wanted to plug a conference I do every spring. Again, if you follow me on Twitter, you would know that I host during Black Maternal Health Week, I host the Black Maternal Health Conference, which is arguably probably one of the largest in the country. Pre-COVID, we would have about 300 to 400 people every year in attendance from around the country. So this April 2021 coming up is going to be virtual. Obviously, we're still in a pandemic, and the focus is going to be on addressing the role of doulas in maternal health disparities. Here are my references, and here are the the two Twitter handles that I mentioned, and then there's a third one I can drop in for the Black Maternal Health Conference. And I'm happy to take any questions. Thank you so much.
Thank you so much, Dr. Mutonakaga. I am glad to entertain any questions from the audience. First, I will ask some of my own questions. So our first question is, how can policy initiatives be structured to center community voices and experiences?
So I'm happy to take that. Any of my co-presenters can jump in as well. Policy initiatives can structure community voices. So that's one of the things we're working on here in Massachusetts, looking at really centering the voices of communities and making sure that communities and their lived experiences are at the table when these decisions are being made. So by that, I mean, how do we really focus on getting the lived experience and the narrative of community into the policy and legislation? So the bill that I recently helped to pass, H 4818, is really focused on that. We are proposing the development of a maternal mortality review commission, not in the clinical sense, but like a maternal mortality commission that would be appointed by the governor, that would have a predisposition to people of color in leadership. So we'd have researchers, clinicians, but an overwhelming majority of people from the community that have lived experience. And how can we use the findings of that to really inform policy here? And so I think that's one of the things I'm really excited about. And also just in all the research I do, one, I always work with community advisory boards, like even in R01, we want to hear from the community. The community are the experts in the room. And two, providing opportunities for community to shape the research question, to, advocate alongside of researchers and clinicians and other advocates working in this area. Like, I really feel strongly that the role of the community is central to policy legislation. And so when I'm invited to meetings and I don't see community members at the table, I always, one, raise the issue, and two, demand that community is invited into these spaces that we as academicians or researchers or people in privileged positions have created, but may not actually have the context that the community can bring. So happy to hear from anybody else on the panel.
Can you hear me? Hello? Okay. Yeah, I totally agree with you, Doctor. Is it Anyukagha? I hope that's correct.
Yes.
Yeah.
Yes.
I mean, I've done, not only clinical work in the community, but also, conducting research. And I think a lot of times I see a lot of times academics will come into communities of color thinking we know everything and we have the agenda without even, getting help from the community in even conceptualizing the problem. I think we tend to sometimes underestimate the communities that we work with in being able to solve a lot of the problems. They know how to, how to problem solve very well. They do it very well on a daily basis. But I think, yeah, definitely having community members at the table when we're legislating to change policy, because as it's not just my bias that I think research and policy help to change outcomes, but the evidence, evidence is clear that this does change outcomes. So yeah, I agree.
Awesome. Our next question is actually from the audience. So how does geography impact public health disparities with, or not just public health disparities, but health disparities in general with pregnant people? Both the impacts of environmental factors such as pollutants, but also the existence or the lack thereof of social support systems.
So Julianne, if you can take the part about environmental pollutants, I can take the social support.
Yeah, so with environmental pollutants and the impact, I guess, that geography has on how those exacerbate or influence health disparities in pregnant people. I mean, we know that there are certain geographies that are more likely to be the locations where facilities that manufacture toxic, or that end up producing toxic waste and toxic chemicals are likely to be cited. And so people who live near those areas, which are historically more likely to be communities of color, just by virtue of where they're born and where they're located throughout their entire lives, are more likely to be exposed to those harmful pollutants. Yeah, so Dr. Anokugawa, if you would like to add to that.
Sure. The second part of the question is, how does geography impact health disparities in pregnant people? So Tori, I guess I'm just curious as to, hold on, let me look at the actual question here. Okay. Yeah, I mean, I think the role of social support is incredible, and just to kind of overlay just the support that pregnant and birthing people need in general, but to overlay that with the disparities we're seeing in COVID, I think geography is really central to the conversation. And even here in Massachusetts, we're seeing different practices and different facilities. So women in one hospital may be able to have a partner and a doula, and then a birthing person in another hospital can only have like one support person. So the role of social support is really kind of transient, particularly in COVID, and we know that's exacerbated for communities of color. So happy to answer any further questions, Tori, but that's what comes to mind just off the top.
Awesome. Moving on to the next question. Multiple panelists stress the importance of community-focused research and engagement. How do we meaningfully include communities that have lost trust in scientists and medical practitioners, and how do we work to rebuild that trust?
I can start off. I think a lot of times, the environment, the culture that we're in as academics is to, they call it the helicopter research, whereby we go in and, we may seem concerned about a problem and really invested, but then when we get all of our data, we're out of there. And so a lot of the interventions, a lot of the things that we do are not sustained. And I think that kind of, just adds to the existing mistrust in academics and science sometimes. So I think the thing I think that takes the longest is developing relationships. With the work that I started in St. Louis, it took at least 2 to 3 years to develop relationships with the kind of non-health uh, places, businesses that were part of the research. And it started with just, kind of, foot on the ground kind of thing, where you walk into um, a salon or a barber shop or a nail shop, laundromat, and you talk. They become familiar with you, but that sometimes goes counter to all of the pressures and all the things as academics we need in order to be productive, or to be to meet kind of all of our needs. But I think there's nothing that can substitute the relationship, the genuineness of engaging with communities, and not just for the time being, but over kind of a sustained relationship, that you can you work with a community from one project to the next. And so I think a lot of it does require relationship over time. So that's all I have.
Yeah, I totally agree with everything that Dr. Wells said, and I think that one of the problems is that a lot of researchers, the first time they enter a community that they want to work with is when they're there to collect data and ask the research questions. I think it's important that researchers begin to engage the marginalized communities that they want to work with earlier on in the research process, when they are figuring out what research they want to do and figure out what matters to the community that they are working with, to make sure they're asking the right questions. Because if it's not a community that researchers are part of themselves, they can't know what the most important things are to the members of that community. And I think also a lot of times when research is done within a community, that community doesn't see any results come from that. Maybe research that comes from that project is published, but most people aren't reading the academic journals that work is published in. And so I think another way to rebuild that trust is to figure out how to translate that academic research into both policy change as well as results that are presented in a way that actually matters to the community where that research is done.
Great question.
I
And
can,
great.
do you want me to respond to that? I know we only have
Of
7
course,
minutes
of
left, so I
course.
don't know if there's,
Yeah.
okay, I just wondered. Yeah, I mean, I think everything that my colleagues have said sounds great. And I would just say that I am very intentional about staffing my research teams with members of the community. So ever since I finished my postdoc, which was in community-based participatory research, I'm very intentional about having community members on my research team, and from beginning of study to the end, from data conceptualization, writing of the grant, submission of the grant, IRB, developing pilot questions, collecting data, analyzing data, being on papers, presenting at conferences, like the whole spectrum. And I think that one, gives you authenticity, but two, it's what you should do, right? You can't do research in communities without having community members at the table. And I think another thing is you have to acknowledge the very well-founded, justifiable history and current context around distrust. Communities are tired of being overstudied and tired of being underinvested in, and that comes from both contemporary and historical references where communities are just exploited and not reinvested in. And so that's really intentional. That is a marker of structural racism and structural inequities. And so communities are really justified for being guarded, really justified for being skeptical. And, you just have to work to build that trust in partnership with communities, not for communities. They don't need us to come in and save them with our fancy charts and metrics. Like, they want to work alongside of us for sustainable goals that are going to be embedded back into that local community.
Absolutely. So moving on to the next question, and this might be a little bit for you, Dr. Mutanakaga. Do you think policies that encourage doulas, the use of midwives or other trained support people, could help people of color navigate their births and empower them?
Yes, absolutely, I do. I really strongly believe in doulas and in all aspects of the work. So I believe in the proper reimbursement and pay for doulas, and that's one thing that we're fighting for here in Massachusetts. And I thought we were going to make some great traction, and it kind of got stalled. But I think doulas need to be reimbursed just like any other provider because they're providing amazing support. There's tons of research that talk about women that have had a doulas in their birth, and it reduces the likelihood of low birth weight, C-sections, increases breastfeeding duration and tension. So doulas are amazing, and also midwives. And I think these trained support people really can serve as a buffer and a layer of protection around women of color as they go into potentially dangerous, harmful clinical encounters. So I had a doula in my birth last year. I have doulas written into both of my grands. I love doulas. And I think that there's enough research and anecdotal evidence to support the use of doulas and other providers in the birthing process for people of color.
Absolutely. And if anyone else wants to add anything to that question, please feel free. Awesome. So our last question for today, we have about 3 more minutes. So one of our attendees has a background in developmental science, and they work with families and children, but their focus is on mental health and psychological well-being. Is this an area of focus in health policy? And if it is, do you have any suggestions on how they can leverage their training in mental health when they apply for fellowship positions with a focus on health? Or in general, are there any suggestions on how people can leverage their training to impact effective change?
I'm happy to take a stab at that. Yes, I think mental health and psychological well-being could be an area of health policy. Are there any suggestions on how to leverage training in mental health? I think if you're coming over to public health, which is an applied science from a clinical science background, it's important to really to be conversant in the language that health policy experts use, and that would be attractive. So, how do you translate your training in mental health, which is really clinical, to a broader population level focus with a focus on preventing illness? That's really public health. Right? How do we prevent illness at the population level for many people through education, research, et cetera? So you just take the skill that you really honed clinically and translate it to a larger population health focus. And I think you should be fine. But everything is about packaging. It's about how you present yourself. And it's about the language and the concepts that you use. So you just have to translate the same skills that you have in mental health, but to a broader population health focus. And I think you should be fine.
And I just have a short short comment just to add to that. I think there's more sort of appreciation of the importance of mental health with physical health. So this whole mind body integrative health. So I think it's becoming even more appreciated, kind of this collaboration of health and mental health, and it's I think increased over since I've got my PhD. I think, you know, as far as training, I think you said something about training in mental health. I mean, you know, there's a lot of grant opportunities with kind of a comorbid, you know, looking at mental health and you know its impact on other physical health. So you know, NIMH is kind of I would say the go-to place, you know, to look for opportunities with regard to national funding, with the kind of a focus on mental health. So.
Okay, everyone, that is all the time that we have here today, but we had excellent presentations on everything from community health and its role in fighting racism, as well as environmental factors and sociological factors in maternal morbidities. Thank you so much for everyone attending, and we hope that you have a great rest of your day. Thank you.